Welcome back to Max's EM Weekly Update, a fast, practical rundown of what's worth reading in emergency medicine this week. This is a lighter week on the literature front, which, honestly, is not the worst thing in the world. So today's episode is going to be focused, efficient, and high yield. We've got one highlight paper, one FOMED review worth your time, and one adjacent specialty trial follow-up that matters for how we think about post-thrombectomy blood pressure targets. Let's get into it. First up, the highlight of the week, an ICOR-commissioned systematic review in resuscitation, looking at airway management with supraglottic airway devices during resuscitation by basic life support providers. The question here is a good one. For BLS providers in cardiac arrest, are supraglottic airways actually better than simple bag valve mask ventilation? This review included 3 randomized control trials and 13 observational studies comparing SGAs with BVM. The pooled randomized data showed no difference in survival to discharge, with a relative risk of 1.28 and a very wide 95% confidence interval from 0.46 to 3.55. That's low certainty evidence, and that interval is wide enough to leave room for benefit, no effect, or harm. In other words, we still really don't know. The observational studies were inconsistent, and the certainty there was very low, especially for neurological outcomes and return of spontaneous circulation. One randomized trial suggested a higher chest compression fraction with supraglottic devices, which is interesting, but not enough to settle the question. One really important limitation: none of the included studies actually looked at true first rescuers, like police, firefighters, or lifeguards. So even if you wanted to generalize this to all BLS settings, the evidence base doesn't really let you do that confidently. What I like about this paper is that it sounds like a systematic review should sound. It was well conducted, used grade methodology, and was registered with Prospero. It doesn't overclaim. It basically says, our enthusiasm for SGAs and BLS may have run ahead of the evidence. That's a useful corrective. We can all come up with theoretical reasons why an SGA might help. Easier ventilation, maybe less interruption, maybe easier for some providers to place. But at least from the data summarized here, there's no clear evidence that SGAs outperform bag valve mask ventilation when used by BLS providers in cardiac arrest. And one detail worth noting: similar emesis rates challenge one of the assumed advantages of SGAs, so even some of the intuitive arguments don't look especially strong here. Bottom line, no evidence currently supports SGAs over BVM for BLS providers during cardiac arrest. For most of us in the emergency department, this probably doesn't change in-house resuscitation management, but it is useful context when thinking about pre-hospital care, training priorities, and how thin the evidence base still is. For now, BLS crews should probably keep doing what they're trained to do and what they can do well. Next up in the foam radar, acute liver failure from EM Ottawa. This is not new primary literature. It's a knowledge translation and clinical review piece, but it sounds like a very good one, especially for a rare, high-stakes presentation that most of us do not see every day. The big value here is pattern recognition and early management. The review emphasizes when to think about acute liver failure in the emergency department: newly elevated liver enzymes, coagulopathy with an INR greater than 1.5, altered mental status, lactic acidosis, and hypoglycemia. That combination should make you stop and ask whether this is true acute liver failure rather than just another patient with chronic liver disease. That distinction matters. The review specifically highlights the importance of separating acute liver failure from cirrhosis because the pathophysiology and workup are different. And unlike in cirrhosis, ammonia levels may actually be useful here because they correlate with cerebral complications. The talk also reinforces the big operational questions: when to involve hepatology, when to transfer for transplant evaluation, and what your supportive care priorities should be early on. In North America, acetaminophen remains the dominant cause, and the review reminds us not to forget about N-acetylcysteine in this population. This is exactly the kind of FOMED resource that earns its keep. No brand new evidence, but a well-organized refresher on a condition where early recognition really matters, and where delays in escalation can be catastrophic. Bottom line, solid review, especially for trainees or as a just-in-time resource if you're actively managing a possible acute liver failure patient in the ED. Last up, a quick look at adjacent specialties: the 1-year outcomes from Optimal BP, published in Stroke. This follow-up asks whether intensive blood pressure control after successful endovascular thrombectomy helps patients at 1 year.
Specifically, after successful EVT in patients with elevated blood pressure, does targeting a systolic pressure under 140 beat a more conventional target of 140 to 180 over the first 24 hours? The answer still appears to be no, and maybe worse than no. Functional independence at 1 year was lower in the intensive treatment group, 40.5% versus 52.7%, with an adjusted odds ratio of 0.59.
The intention to treat p-value came in at 0.051, so just above the traditional cutoff, but the per-protocol analysis was significant, and importantly, the direction of effect matches the original 3-month signal toward harm. There was no mortality difference. So while the intention to treat result is technically borderline, the overall message is pretty consistent. After successful thrombectomy, early aggressive blood pressure lowering does not look beneficial and may be harmful. The practical takeaway is the same as before. Evidence does not support aggressively pushing systolic blood pressure below 140 in these patients. A target range of 140 to 180 systolic in the first 24 hours continues to look more reasonable. Most of us are not managing these patients independently for long stretches in the ED, but this is exactly the kind of adjacent specialty literature that matters.
A final practical pearl from this week. All 3 pieces are really reminders to respect the basics. In cardiac arrest, good fundamentals may matter more than chasing a device that feels more advanced. In acute liver failure, the win is early recognition and early escalation. And in post-thrombectomy care, sometimes the better move is avoiding overcorrection rather than pushing physiology toward a target that feels cleaner on paper. That's a theme worth carrying into a summer shift. Do the simple things well, know where the evidence is thin, and recognize the rare high-stakes patient early.